Okay, so again, welcome everyone to this presentation today. Before we get started, I would like to read a land acknowledgement. The Alzheimer Society Huron Perth gratefully acknowledges that the geographic area we support is located on the traditional lands of the Ojibwe, Chippewa of the Anishinaabe, and the Haudenosaunee and Neutral people. We recognize and deeply appreciate the historic and ongoing Indigenous connection to this place. And as a community, we will work together to peaceably share and care for the resources around the Great Lakes. We commit to our ongoing learning in our journey towards reconciliation. So I would also like to thank some of the sponsors for our presentation. I would like to mention the Finding Your Way program. That is a program that supports the Alzheimer Society of Ontario and all of the chapters. Finding Your Way provides resources for living safely in our community. You can find out more about that at findingyourwayontario.ca. And I would also like to mention that we do have our Walk for Alzheimer's coming up soon. That will be on Saturday, May 27th. We will have in-person walks in Stratford, St. Mary's, Listowel, Clinton, Wingham, Goderich, and Exeter. If you would like to find out more information, please contact the Alzheimer Society of Huron Perth. I'm Jeanette Sears. I'm the Public Education Coordinator for Alzheimer Society Huron Perth, based out of Clinton. My co-Public Education Coordinator, Christy Bannerman, is here from the Stratford site. We also have Sarah Best and Julia Tremner from Dr. Borrie's lab. So thank you all for being here. And I would like to introduce our speaker for this afternoon, Dr. Michael Borrie. So Dr. Michael Borrie is a geriatrician and professor in the Department of Medicine, the Division of Geriatric Medicine at the University of Western Ontario. He is also the medical director for the Aging Brain and Memory Clinic and an investigator with the Cognitive Clinical Research Group, as well as the past president of the Consortium for Canadian Centres for Clinical Cognitive Research. His research interests have included investigator-initiated studies for predictors of conversion from mild cognitive impairment to Alzheimer's disease. He's also the platform lead for the comprehensive assessment of neurodegeneration and aging, observational study of the Canadian collaboration on neurodegeneration in aging. And since 1995, which is 28 years, if my math is correct, the Canadian collaboration on neurodegeneration in aging has been a leading Canadian research site conducting trials of potential new treatments for cognitive decline, mild cognitive impairment, and Alzheimer's disease. So Dr. Borrie brings just a wealth of information and expertise. We are so looking forward to hearing what you have to share with us today, Dr. Borrie, as we learn about what's new in Alzheimer's disease research.
Thank you very much, Jeanette. Welcome, everyone. Good afternoon. I need first just to go over my disclosures. Our group has received research support from the peer-reviewed agencies on the left, and also clinical trials funding from the companies listed on the left and the right. And these funds are paid to the Lawson Research Institute, and that supports both our conduct of pharma-sponsored clinical trials as well as investigator-initiated studies. I've also received consulting and fees for advisory panels and continuing medical education programs to educate family physicians about Alzheimer's disease and its management. So today we want to cover these 6 learning objectives briefly, to review the lifetime risks for dementia and how to modify them, to review the Alzheimer's disease drug development pipeline, understand the current theories for Alzheimer's disease and the development of biomarkers of the disease, both in blood, cerebrospinal fluid obtained from a lumbar tap, and also positron emission tomography scans, or so-called PET scans, which we will look at a little later. Explore some of the latest randomized controlled trial data from the Lecanemab study published at the end of November and approved conditionally in January of this year, and will be considered FDA full approval next month. We'll discuss the side effects from intravenous antibody to remove amyloid protein from the brain, and also review some of the current intervention and observational studies being conducted at our site in London, as well as other sites in Canada. So people who have cognitive impairment fall somewhere along what we refer to as a spectrum of cognitive decline. And on the far left, you have people who are regarded as being supernormal. These are people 80 and over who score the same as 20-year-olds on memory screening tests, typically a mini mental state exam and the Canadian equivalent, the Montreal Cognitive Assessment, or MoCA. Some of you may be familiar with that test. People, as they get older, do have a decline in their cognitive abilities. It's normal age-consistent loss, which begins at about age 45. If you look at the cohort studies, including the Whitehall study, looking at cohorts of people by 5-year age groups, and you see this very subtle decline begin. It's something that people are not aware of, and certainly people are not concerned about any changes in their memory, and they score normally on tests like the MoCA. People with subjective cognitive decline say there's been a change. They perceive there's a change. This may occur during their work or in retirement, and they are concerned about it, but they score normally on the MoCA as well. People with mild cognitive impairment not only have the observation of change and decline in their memory, but they score in an impaired range below 26 out of 30 on the MoCA, so 26 or less, less than 26 out of 30. But the instrumental activities of daily living are intact, and they may be a bit slower in doing some of these activities. People with dementia not only have impairment on their cognition, but will be impaired on one or more of the instrumental activities of daily living. And the examples that are given there are cooking, tracking finances, managing medications. And these are some of the changes that occur early on. And when we look at dementia, underneath that umbrella of dementia, the underlying causes, most commonly Alzheimer's disease, vascular dementia due to small strokes or sometimes larger strokes. Sometimes you may have people who have both combined Alzheimer's pattern of decline as well as a vascular change with sudden drops after strokes. Lewy body disease characterized by people who have visual hallucinations, Parkinsonism, and fluctuations in the levels of consciousness. Those are the 3 most common symptoms we see to make a diagnosis of Lewy body disease. And then frontotemporal dementia, people presenting with disinhibited behavior or language disorders. On the right, you can see other conditions, rarer forms of cognitive impairment. In 2020, Livingston and others published this article or paper in Lancet. And what it shows is the risk factors that are potentially modifiable for dementia. And you can see the potentially modifiable ones amount to about 40% of risk. However, there is about 60% of risk of dementia, which is unknown. And you can see that this changes during the lifetime. So education is important early in life. Hearing loss, which can be corrected and might make a difference in the trajectory of cognitive impairment, is certainly important. You can read the other conditions, which I'll speak about there as a person goes through and are more likely to develop comorbidities later in life, such as diabetes, high blood pressure. Strategies to reduce the risk and manage cognitive impairment, and there's increasing evidence for all of these things over time. Just to go through them briefly: regular exercise, and walking would be the most common form of exercise. It could begin with 10 minutes at a time, increasing up to an hour, 3 times a week. And this is brisk, purposeful walking, or other forms of exercise, whether it's indoors or swimming or some other sort of activity that people like to do. Diet, there are various diets. We focus primarily on the Mediterranean style diet, as the wealth of evidence for that from observational studies is quite robust. Restorative sleep, which is not disturbed at night, is important. Shifting fluid intake to the mornings or middle of the day, rather than loading up the fluids at night and then having disturbance because of the need to void. Mental stimulation, different types of activities. People do word searches. Most recently, during the pandemic, people have been doing Wordle or Quordle, which is some of these other activities which really stimulate you to think about words. And what you're trying to do there is to get some of those neurons in the brain, we have billions of them, getting them to talk to each other. Socialization is obviously important, whether a person's working or whether they're retired. Lifelong education, managing stress, avoiding brain injuries. Hygiene of dental hygiene is important, particularly for people as they start to develop cognitive impairment and dementia. These may be at increased risk of worsening of conditions like diabetes or risk of aspiration pneumonia, where there's poor dental hygiene, and overall health can decline. Cardiovascular disease can be affected by this as well. Air pollution as well. Alcohol reduction and the Canada guidelines, most recently in January, 2 drinks per week. Anything higher than that increase the risk of various cancers, but also alcohol will affect cognition. And if a person already has cognitive impairment, it's important they reduce and even stop drinking altogether and going to non-alcohol options. Still can drink beer, maybe. We commonly talk about the Partake brand, which is a common one, which is in grocery stores, but many other brands as well as non-alcohol wine. The vascular risk factors are listed there, and these need to be detected, treated, managed, and monitored. Kidney impairment, which can arise from a combination of diabetes or hypertension. Depression can be treated with non-drug and drug treatments, and then hearing impairment needs to be addressed, and AIDS. So if we look at some of the data from combination studies, and this is just one important longitudinal study, it's a cohort study following people over a period of 9 years across the x-axis at the bottom, you can over 12 years, and you can see the probability of remaining Alzheimer's disease free. And they broke the participants in this large observational study up by the group, high physical activity and high diet score, compared them to others. For example, the dotted line there, people with low physical activity and low diet score. And you see the difference in the probability of remaining Alzheimer's free. So after 12 years, people in the higher group, about 80% still Alzheimer's free, whereas people who are in the low physical activity, low diet score group have progressed to dementia, about 60% free still of dementia. An important study done in Finland, the FINGER study, 2 years, randomized controlled trials. So people being randomly assigned to 2 different arms of the study. One arm of the studies, they had 4 interventions. So these participants already had some risks for cognitive impairment, such as some vascular risks, high blood pressure, diabetes, being overweight. And they had to have some risk, and they had to be between 60 and 77. Then they received instruction and on nutrition, physical exercise, cognitive training, vascular monitoring, versus the health advice group, who were the control group, just got the advice. They found that there was improved cognition, reduced risk of cognitive decline for the intervention group. Alzheimer, 100 years ago, more than 100 years ago now, looked at one person, and this is a representation of what he saw. So normally we would have neurons, which are quite healthy neurons there, and this is showing them connecting to each other and having with their dendrites and synapses. And it's on a background of a fairly normal, what we refer to as cytoplasm. Nerve cells can have up to 2,000 connections with other nerve cells. So there's a tremendous potential for connections to be built. And we have billions of these nerve cells in our brains. People with the one he saw with Alzheimer's disease had in the cytoplasm these plaques that he referred to. Now we know that these are due to amyloid protein, and I'm going to talk a bit more about amyloid protein. And secondly, he described tangles or neurofibrillary tangles within the nerve cells. So they occur due to misfolded tau protein. So you've got misfolded amyloid protein causing the plaques and misfolded tau, TAU protein causing the tangles. So advanced more than 100 years, and we now have this model for actually describing Alzheimer's disease pathology in the brain. So if we look along the bottom axis, the x-axis, it goes from left, from normal through the preclinical phase where a person is starting to develop the underlying pathology but have no symptoms. Certainly by mild cognitive impairment, they already have some symptoms, and then evolving further in dementia. And that clearly goes over a period of years. And on the vertical axis, you've got some sort of biomarker, which I'll describe for representing each of those lines with increasing abnormality the further you go up that vertical axis. And so in the red, you can see amyloid accumulation. So this is amyloid protein, we call it amyloid beta protein. And this is accumulating in the brain with those plaques and those deposits. And in the cerebrospinal fluid, it is becoming lower. Normally, this is certainly amount of normal amyloid in the protein, normal amyloid in the cerebrospinal fluid, but as it's deposited in the brain, it becomes lower in the level as the disease progresses in the cerebrospinal fluid. The yellow line represents the connections between the nerve cells, or the so-called synapses, and synaptic dysfunction. And this is measured a couple of different ways with using imaging. And you've got FDG PET, which is the glucose PET scans, which shows the function of the nerve cells. Nerve cells run on glucose, and so you can do PET scans with glucose scans and show the drop-off in the glucose activity in the brain. The functional MRI shows, it's a magnetic resonant imaging technique which shows the function of the cells in the brain. The green line represents neuronal injury that's occurring over time. You can see this is occurring sometime later, maybe even 10 to 20 years later after the amyloid has actually started to deposit in the brain. And these two things are linked. We know that the amyloid and the tau seem to be linked, and the tau misfolded proteins cause the injury to the nerve cells, and you get tau abnormal protein rising in the cerebrospinal fluid over time with the progression of the disease. So these are things important to remember, because we're going to come back later to how these biomarkers performed during the Lecanemab trial. Later on, as you're starting to get symptoms with mild cognitive impairment, you'll start to see structural changes in the brain, and this is measured using regular MRI scans. So this is a later finding. So the disease is well on its way by the time you actually start to see volumetric changes in the brain, and by that we mean shrinkage. So the brain itself is starting to shrink. You can see it, evidence of shrink with widening of the sulci, the wriggly parts of the brain, and the gyri, the wriggly parts, and the sulci, the areas between the gyri, and shrinkage also of the memory department called the hippocampus, which is affected early on with the disease. Later on, cognition as measured by the mini-mental state or the MoCA score starts to change and decline. And we said earlier that in the spectrum of cognitive decline that occurs in mild cognitive and continues on into dementia. And once you get into the area of dementia, this is where a person's activities of daily living are starting to decline as a measure of clinical function. This wheel represents all of the trials in 2022 that were being conducted as part of efforts to advance the understanding of Alzheimer's disease. And we're going to focus on the green segment above with the disease-modifying biological compounds. You can see in the purple segment, you've got disease-modifying small molecules. In the blue segment, you can see neuropsychiatric symptoms, a smaller number of compounds trying to address that. And then there's also, on the orange area, cognitive enhancers. And you can also see on this wheel, there are 3 lines, concentric lines, phase 1, phase 2, phase 3. And these are the different phases of clinical trials. And phase 1, 2, and 3 refer to the human trials in people. And we're going to focus on phase 3, and you can see right in the center of there, Lecanemab. So this is most recently been published, and there are obviously some other compounds that are on the way. Donanemab, for instance, is another one that we're waiting to see the readout on that particular compound. Aducanumab, above that you can see, has already been approved conditionally in the United States, but not in Canada. So to summarize that pie diagram, there are a lot of trials, but you can see as you go through from phase 1, 2, and 3, you get a drop-off of these different compounds. Disease-modifying therapies represent the majority of candidate treatments. Also, the thing to pay attention to is that to conduct the trials require a lot of participants, people willing to participate in the trial, either people normal controls or people with SCD or mild cognitive impairment or Alzheimer's disease who are willing to participate and donate their time to participate in the trials. And they often will require not only a person who participates, but a study partner to be in that trial. A lot of these trials are supported by pharmaceutical industry, and a number of them will also be done in partnership with pharmaceutical companies and peer review funders, so a hybrid of funding. And a lot of the studies are done outside of North America, so it really is very much a global effort. Often with some of these studies, there'll be studies being conducted in many different countries with only a number of sites for a particular trial in Canada. I'm going to talk about PET scans, the amyloid positron emission tomography, first published in 2004 by Klung in Pittsburgh. And what a PET scan does is it detects in life amyloid protein, which has been deposited in the brain, as plaques. So we can now see these plaques, not individually, but as a load of amyloid plaque in the brain using this PET scan. Now, a negative amyloid PET scan can rule out a diagnosis of Alzheimer's disease up to that point in time. If a person is at risk of that because of, say, a family history or because they are ApoE4 positive, 1 or 2 copies, that's a risk gene for Alzheimer's disease that sometimes is passed on through various families. For instance, ApoE4, if one looks at that in London or in Canada, for instance, about 15% of people have 1 copy of ApoE4 and 3% have 2 copies of ApoE4. And this particular gene substantially increases your risk of Alzheimer's disease. And detection of the amyloid I mentioned earlier, we can detect that 20 years before the tau protein causing the neurofibrillary tangles starts, which then leads on to the symptoms of cognitive impairment as large numbers of neurons are lost. The plaque detected on a positive PET scan in normal people or people with mild cognitive impairment is associated with increased risk of dementia. So even if a person has no cognitive impairment now or has to have mild cognitive impairment, those people with a positive scan are at risk of developing dementia compared to people who have a negative scan. The traces that are used, Pittsburgh B compound or PIB-B, PIB was the first compound, half-life of 30 minutes. They developed other compounds using the F18 molecule, and these half-life of 2 to 3 hours. It means the compounds can be made either in London or outside of London and driven or flown into London. They are injected intravenously into a participant who then goes into the PET scanner. And if the amyloid is present in the brain, the tracer will bind to that amyloid tracer in the brain, and the PET scan will light up as being positive. And the amount of accumulated amyloid is measured using a centiloid scale, which goes from 0, no amyloid, up to 100, which is a lot of amyloid. Now, amyloid can also be measured, this abnormal amyloid, normal amyloid and abnormal amyloid can be measured in the cerebrospinal fluid. People with Alzheimer's disease shows a reduction in amyloid. So it's been deposited in the brain, it declines in the cerebrospinal fluid. And we obtain that from a lumbar puncture or spinal tap. And that can be done as an outpatient procedure under local anesthetic. And then there are two types of amyloid protein. The amyloid protein comes from a larger parent molecule. The parent molecule has 90 amino acids, but then it is cleaved by different enzymes and broken down to this toxic form, the A beta 42, and there's also an A beta 40, which tends to deposit in arterial blood vessels in the brain. And that ratio of A beta 42 over A beta 40 is even more accurate way of measuring decline in the cerebrospinal fluid, and it will predict progression to dementia. Amyloid can also be measured in the blood. Now, this is a new development over the last 2 or 3 years using a single molecular array or Samoa technique, and they can make this measurement now feasible. When we measure it in the blood, the A beta 40, it's more difficult to measure and is lower in the blood compared to the CSF where it's concentrated. And the part of the reason it's lower in the blood is that amyloid protein in the blood can also be derived from other sites other than just the central nervous system. Tau protein brings together and stabilizes microtubules within the neurons in the brain. That's its function, that's its normal function. However, in Alzheimer's disease, for some reason, this tau protein develops additional chemical bonds, phosphorylation bonds, and these are excessive and become hyperphosphorylated, leading to the formation of these tangles. So you get these misfolded proteins now because of these additional bonds. And this occurs within the neurons, and this then leads to the death of the cell, which we refer to as neurodegeneration. That's the death of those nerve cells. Now, tau protein can also be measured with a PET scan, and this was first described in 2014, so just 9 years ago. There are 3 different traces mentioned there, very sensitive and specific for the diagnosis of Alzheimer's disease. And the tracer accumulates, and it begins in the part of the brain responsible initially for short-term memory spreading from the entorhinal cortex to the hippocampus and the subiculum. And this pattern that you see of spreading on the tau PET scan follows the same progression described by the neuropathologist Braque, who described in the 1990s, based on autopsy examination of the brain, the pattern in people with very mild disease through to severe disease, and the Braque rating scales going from 1 up to 6. And this scale that you see on the brain and on autopsy described by Braque is the same pattern of progression that you see in real life with these tau PET scans. And the pattern of spreading follows the typical clinical presentations. So for those of you involved with family members with Alzheimer's disease or people who are presenting themselves with cognitive symptoms, there's three different common scenarios or symptom clusters mentioned there. There's the typical memory loss of Alzheimer's disease, what we refer to as amnestic symptoms. That refers to the short-term memory loss. There's also people who present with language problems and word-finding difficulties as the first symptom they have. We call that the logopenic aphasia. And also the people who have visuospatial impairments, so visuospatial disorientation. And these patterns of clinical symptoms correlate with changes of the tau deposition in the areas of the brain listed to the right of those. Tau is now also being investigated as a possible indicator to determine the progression of the disease. And so this might be helpful in the later on to actually determine the prognosis or indicator of progression of the disease. So this image here shows the combined amyloid and tau PET scans in 4 individuals. You can see along the bottom, CN represents cognitively normal, 3 people who are cognitively normal, and 1 person with Alzheimer's disease dementia. In the top line, you can see the A-beta PIB scan. So this is using that short 30-minute tracer, the original one. And you can see that the first 3 people, even though they're cognitively normal, have varying, increasing amounts going from left to right of amyloid protein in the brain, and to the far right, quite a lot of amyloid in the brain. And you can see on the bottom line that same individuals with tau, you can see the progression of, you can see tau progressing in the images there. And you can see, particularly the one on the right with the Alzheimer's disease, the purple area is representing the entorhinal cortex and hippocampus subiculum. That's the part of the brain that's affecting memory. In the New England Journal in November, they published the phase 3 trials of Lecanemab in early Alzheimer's disease, and it was also presented simultaneously at the Clinical Trials Alzheimer's Disease Conference, or CTAD. This is an annual conference which began in 2008, and all of the findings from clinical trials, whether they're negative or positive, are presented at this conference. And so this is something that our team with the Cognitive Clinical Research Group actually participated virtually, seeing the presentation of this information, which I will present shortly. Lecanemab is a human-like monoclonal antibody. So this is an antibody which is produced, and it has an ability to stick to, or an affinity to stick to, soluble amyloid, what are referred to as protofibrils. So these groups of amyloid molecules. Amyloid beta 42 is a very sticky molecule. It begins off as a monomer, a single molecule, and that will join to a dimer, and that will join to 2 dimers will come together and form a quadramer. And before you know where you are, you've got these protofibrils, which are very toxic to neurons. And then you get the insoluble fibrils. And the insoluble fibrils are the ones that are in the plaque. But this is what lecanemab has an affinity for several species of A-beta 42, but in particular, the protofibrils. So the people in this study between ages of 50 and 90 with Alzheimer's disease, they either had mild cognitive impairment or mild dementia, clinically determined in the clinic. And then they had to have evidence of amyloid accumulation using the PET scan or cerebrospinal fluid. And that depended on the site that they were participating in. Some sites don't have the PET scan capability. And then they were randomly assigned either to be in the treatment arm or the placebo arm. They don't get to choose. They are randomly assigned, and they get intravenous treatment, intravenous antibody, 10 milligrams per kilogram every 2 weeks, or an equivalent lookalike placebo. And this goes on for 18 months. And then there are some endpoints that you want to have that you're going to compare at the end of the trial. So we start with the primary endpoint with a scale called the Clinical Dementia Rating Scale, sum of the boxes. So I'm not going to go into this, but it does involve the this particular scale involves input from the participant as well as the caregiver. And then there's a secondary endpoint, which is the change in the amyloid burden. Do you actually manage to remove amyloid using lecanemab? The change in the Alzheimer's Disease Assessment Scale, this has been available since the 1990s as an outcome measure in clinical trials. It's been refined over time more recently. The ADCOMS is a measure used in people with mild impairment. And there's also an activities of daily living scale to capture the change in function. So this was the data that was presented at the CTAD conference that we all saw. So to describe this graph, you can see across the baseline going from left to right, 0 through to 18 months. So that's the duration of the trial. And up the vertical axis, you can see at the top 0 going down to 1.6. And what this is showing is that as you go down that scale, you get worsening. And across the bottom, you can see across at the different visit times as part of the clinical trial, you can see in black the people who were in the placebo arm and the participants who were in the green in the lecanemab arm. Now, if you look at the two lines on the graph, both of the graphs are sloping from left to right. They're going down. So both groups are getting worsening. But the other thing you can observe is that the two lines are spreading apart. And what this shows is that they're not parallel, but they're slowing in the lecanemab arm, the green arm. And this is calculated to be a 27% slowing over the 18 months. And the other point where you can see the first ringed area, you can see the error bars don't overlap. So by 6 months, we can say at that point, because the error bars don't overlap, that this is at least statistically significant at that point. Obviously, you want to know, is this clinically significant? Is this a clinically meaningful change? And that's what part of the discussion is. If we look at the ADAS-Cog, you see the same pattern, just see the same slope and the separation of 26% slowing with another cognitive measure, the ADCOMS, 24% slowing with lecanemab. And then if we look at the function, now this is the ADL scale, again, the same principle across the bottom line, 0 to 18 months, the vertical line, you can see decline in function, but less decline in the people participating in the trial receiving lecanemab, 37% slowing by lecanemab over 18 months. Amyloid PET was done in a bit less than half of the participants. That depended on whether PET was available at that particular clinical trial site. And you can see, again, across the bottom, 0 to 18 months, you can see the vertical axis as you go down, 0 down to -60. This is less amyloid. So you can see the people in the black line across the top, slight rise in the amount of amyloid. It's slightly accumulating, and you can see the people in the green arm of the trial, the lecanemab, there's a significant decline. So there's a 59% decline on the centiloid scale over 18 months. Now, to explore that a little bit further, that same graph, if we look at these two participants on the right, in the top box, there's the person with placebo. There are 3 images there, and these are PET scan cuts through the brain at 3 different levels. And these are cumulatively evaluated, and at baseline, that person there you can see had 79.45 centiloids. And after the 18 months, it had risen slightly. They're now at 84.44 centiloids. And in the baseline for the bottom person, again, a similar score on the centiloid scale, 80.33 at baseline. But after 18 months of lecanemab, the centiloid scale measurement on the PET scan repeated at the end is 22.0 centiloids, showing that amyloid has been removed from the brain. So to summarize the findings from this trial, the trial met all the primary and secondary endpoints. The clinical dementia rating scale declining by 27%, the amyloid PET reduced amyloid burden even at 3 months. If I just go back there, you can see that that first red circle, you can see there that there is a substantial reduction in the amyloid even within 3 months. So this is occurring very early on with the treatment. And then the ADAS-Cog and the ADAS-Com both slowed progression, and then the activities of daily living slowed progression. We need to talk about side effects because no treatment really has no side effects. Most treatments of any drug trial will have some sort of side effects. And we need to understand something about ARIA, which is amyloid-related imaging abnormality. That's what ARIA stands for, and the H stands for hemorrhage. And this really is referring to microhemorrhages. So if we look at, in the normal population, if we evaluate microhemorrhages, and we do this using MRI scans, we can't see them on CAT scans or plain X-rays. We have to have special sequences on MRI scans, gradient echo images. And we can see there in the general population, you can see the 5 different groups across the bottom axis, and you can see the prevalence of microbleeds on the vertical axis here. So general population, 5% will have microbleeds. People with mild common impairment, a higher proportion will have microbleeds. People with Alzheimer's disease, over 20%, will just have spontaneous microbleeds. And this is really reflecting that they have that amyloid A-beta 40 deposited in the blood vessels, and it's probably those weaken the blood vessels and cause these spontaneous microbleeds. These are tiny bleeds. People are not aware of them. If you had a microbleed, you wouldn't know it. You wouldn't present necessarily, a single microbleed wouldn't present as a headache or even any symptoms at all. People with ischemic stroke, they have many more microbleeds, and people with hemorrhagic stroke, where there's a bleed into the brain, this is a situation where a microbleed has converted to a macrobleed, which is a much larger bleed and actually been sufficient to cause a stroke. So that's sort of the natural affairs, state of affairs with spontaneous hemorrhages that may occur in the brain. So now we can look at the overall adverse events and side effects from the trial. So we look at the overall deaths. We can look at the placebo group on the left and the lecanemab group on the right. And if you go down these columns, you have a number, which is the total number of people, and in the brackets, you have the percentage. So you can see that the deaths were comparable between the placebo and lecanemab. And with older individuals over the course of 18 months, you might expect some people to die. Serious adverse events, slightly higher in the lecanemab group, 14% versus 11.3%. So serious adverse events do occur even in placebo. And this is the importance of having placebo-controlled trials, because what you're doing here is controlling for the natural events that might have occurred anyway, just by chance. Now, if you come down a bit further, you can see treatment emergent adverse events, AEs, the TEAE, that line, 5 lines down. And you can see they're slightly higher in the lecanemab group compared to the treatment group. And also that some of those events leading to drug withdrawal was slightly higher in the lecanemab group. We can look also at adverse events of special interest, because what we were interested in looking at was infusion-related reactions. So if a person had a reaction to the infusion, was that higher in the treatment group, in the people on lecanemab? So you've got the 2 columns there, and you can see placebo 7.4. So even people with a placebo with an infusion of a placebo, they will have a reaction to it. And these reactions commonly are local skin reactions to the infusion. And then area E refers to amyloid-related imaging abnormalities, edema, this is where you get some swelling in the brain. And I'll show you some pictures of that in a moment. So you do get some in placebo, on the placebo arm, 1.7%, but 12.6% in the lecanemab arm. And then the hemorrhages, 9% spontaneously occurring in the placebo group and 17.3% in the lecanemab group. And then other side effects which occur more than 5% listed there. And they're fairly evenly balanced, apart from headache, which is slightly higher in the lecanemab group, because some of the people who would have had area E and area H would have also presented with headache, although most of the people who have swelling in the brain had no symptoms. About 85% of them had no symptoms. So this is a slide really to try and help us understand the relationship between the PET as measured using the Pittsburgh B compound, area E and area H. And this came from an earlier trial with babenusamide. This trial was conducted as an earlier compound between 2008 and 2010. And this is in a person with ApoE. This is a person who is at increased risk of Alzheimer's disease. We also know that people who are ApoE are much more likely, who are ApoE positive, are much more likely to develop area E or area H. So if you go to the left-hand screen, the screening flare image, this is an MRI image. We can see there, this is a review, what's called an axial view. It's sort of a cutting through the brain, horizontally through the brain, and showing the ventricular system in the central part of the brain. And you can see the next image, a screening PIB scan, showing the amyloid primarily at the front of the brain, the red area at the front of the brain. And then at week 6 after an initial treatment, this person has some white areas where the arrows are marking there, these subtle white areas. And this is some swelling in the brain locally where that amyloid is. And then if you go down to the bottom left-hand image, week 19 is a flare image using, you can see on this image that the swelling has resolved, but at the middle image at the bottom there, you can see that the PIB shows that the amyloid has been removed or certainly substantially reduced. And at the front, you can also see particularly the bottom gradient echo, you can see a dark area, and this is a microhemorrhages that have developed having removed the amyloid from the brain. And this further image shows that if you concentrate just on the baseline PIB and looking at the lower PIB, you can see image, PET scans in the center there, you can see that there is a reduction in the PIB with this treatment, babenusamide. And then this further image showing that these findings suggesting that area E and area H are probably related, are occurring, this is what we believe, to the clearance of amyloid from the brain, those plaques from the brain, because the amyloid has gone down, the amyloid plaque has gone away or been reduced in the brain early on in the treatment trial, and that you also have these side effects, this area at E, the edema in the brain, which resolves by 19 weeks on the repeat MRI scan, the safety scan, and then the hemorrhage, the microhemorrhages, where the amyloid has been pulled out of the brain. We want now to look at the biomarkers of tau during this trial. So they also measured tau biomarkers. There's smaller numbers of people here that actually had the cerebrospinal fluid. So if you look at the left-hand graph there, you can see 0, 12, 18 months lumbar puncture. These people who have had lumbar punctures at 3 times. And the black line, you can see that the tau level is rising, going up to the right, and the green or lecanemab treated arm, that the tau markers have actually decreased during the course of the trial. And if you look to the right image, you can see the tau measured in blood. So now we can see that the tau level in the blood is remaining more or less the same in the people who are on the placebo arm. And if you look at the green arm and the right arm, on the right hand image, you can see that the measure of tau in the blood is going down. So what does this mean in the future? We can use blood biomarkers in clinical trials, and in fact, we are actually using it in clinical trials. So if we take general population of people and did a blood test, we could actually determine whether they might be healthy or whether they may be at risk of developing Alzheimer's disease based on the blood test. And so for some of our studies now, we're using the blood tests to actually identify people who may have a positive blood test, and if it's positive, then they can go on and have a PET scan, and if the PET scan is positive, then they can participate in the trial. But this actually allows one to be identify people who have the underlying pathology in the brain. You don't want to be offering a treatment to a person who doesn't have the underlying treatment. And this is going to be important in the future when we look at clinical populations in primary care. You will have people who may have cognitive symptoms, people who are presenting to their family physician with memory complaints. They may be able to have blood tests, and this may be able to differentiate people who have low probability, so a negative blood test versus a person with a medium probability, and they may need to go and have additional testing and assessment, say through a memory clinic, or high probability where they may be offered particular treatments. So that's what the future may look like. That isn't here right now. Those blood tests are still research blood tests, but they are coming, and they've been developed in the last 3 years. We do have a trial now for people who have normal memory, and this is a Lecanemab trial. So you can imagine that spectrum of cognitive decline. We're moving from mild impairment to and Alzheimer's disease, moving back along into that group who have normal people, but who are at risk of developing Alzheimer's disease, usually because of a strong family history of Alzheimer's disease. So for the HEAD study, A345, and this is going to be led, or is being led, by Dr. Jaspreet Bangu, one of our new geriatricians who have joined our group. There are 2 trials here, A3. These are people with early preclinical Alzheimer's disease. So no symptoms, but their amyloid level on the PET scan is between 20 and 40 centiloids. So you may remember that the people that participated in the Lecanemab trial with mild impairment and Alzheimer's disease, most of them had a centiloid score of around 80. These are people who have much lower score, 20 to 40. And then there's going to be an A4 group, and these are people with elevated amyloid on the centiloid scale of more than 40 centiloids. So to participate in the study, people usually will have a family history, but not always. Evidence of amyloid on the PET or on cerebrospinal fluid. At our particular site, we're offering it is with the PET scan. And then they're randomized to being on intravenous lecanemab, because lecanemab is still being given intravenously, although there are other studies going on to evaluate it and see if it can be given subcutaneously and have the same effect. That's another trial and another area of research. They have to be normal, cognitively unimpaired, between ages 50 and 80, and if they're between 55 and 64, they must have one other risk factor. So they may have a copy of ApoE4, so they may be at increased risk because of that. They may already have had a PET scan somewhere as part of another clinical trial, or for some other reason they've had a positive PET scan. They're not clinically available. We can't order them. A family doctor can't order them. A specialist can't order them. Certainly in Ontario, you can't get an amyloid PET scan. They cost about $5,000 each, and they're not covered. But some people have had them in the US, for instance. I'm not encouraging people to go to the US, but they are expensive to get. Or they may have a first-degree relative who had onset of dementia before the age of 75. And then it's a 4-year study. The people in the A3 arm get a monthly infusion. The people in the A4/5 arm have an infusion every 2 weeks, up to 2 years, and then monthly. And then they have primary endpoints. So the primary endpoints in these trials are going to be amyloid clearance of the brain, because they're cognitively normal. There's no point doing cognitive tests, because these things are not going to change as your primary outcome measure. And the people with A4/5, they will also have the a composite of preclinical Alzheimer's disease cognitive testing, so one that's even more subtle for measuring subtle changes in memory over time. We also have some new observational studies at Parkwood, and these have been very important in informing how we design and conduct Alzheimer's disease, both from a safety perspective and also an effectiveness perspective. So Alzheimer's Disease Neuroimaging Initiative, or ADNI, began in 2006. And our site has been the lead site in Canada for that. And there are 60 sites altogether in North America. And what we've found with the conduct of those trials, there's an overrepresentation of white English-speaking and college and university-educated participants. And so we're now going to focus on recruiting people from underrepresented groups, from the BIPOC communities as well as Spanish-speaking people. And we hope to be able to offer that at our site as well. Comprehensive assessment of neurodegeneration and dementia, the COMPASS ND study. We're the lead site for this, and I'm very proud of the efforts our site have made, and all of our coordinators and our research manager, Sarah Best, who's led this. Julia Trimner has played a really important role in helping us with all of our trials in terms of recruiting people into these studies. And so what we're going to be looking at here is trying to focus on recruiting people for the phase 3 in this trial, on participants who have up to grade 12 education, but in addition have life experience education to that, to try and have more people from that particular group represented in our studies, so that is more generalizable to the population. So I want to thank our participants and our study partners who have continued to participate in the observational and disease-modifying trials in order to advance our understanding of cognitive impairment. And this is the contacts for any of you that may have interests, have further questions. Please leave a message at the number there, or email us. We're also on Facebook. And Dr. Bangu, myself, and Dr. Wells are the investigators from geriatric medicine. We collaborate very closely with Dr. Elizabeth Finger and Stephen Pasternak in cognitive neurology. Sarah Best, who's on this call, is our research manager, fearless and helping us conduct all of these studies and recruiting. And we have an amazing staff who have been with us for many years. Chrissy Coleman has been helping Dr. Finger and Dr. Pasternak with their particular trials. And we, as part of a team building exercise, we went out together, and here we are doing the MOCA on some llamas and some alpacas, and you'll be happy to know that they all passed. So we can stop there, and I'd be happy to answer any questions.
Thank you so much, Dr. Borrie. That yes, that's so fascinating. All of the information that is out there. Yeah, I know when we are out, when Christy and I are out and about, we do get a lot of people that are interested in the research that is going on for the AHEAD study, and the COMPASS ND study sounds very interesting as well. Are there any questions? I will open it up now. Or actually, maybe before I open up to questions, I am going to stop the recording, so people feel free to ask without it being recorded. So thank you to everyone who's listening on the recording. There we go.